thanks to all of you in the room. It's great to be here in person. I've done a lot of talks on Teams, which have gone reasonably well, but the live one feels a bit more daunting, but hopefully I'll be saying much of the same stuff before. I did do this event, I think, a couple of years ago when Richard's report came out, and we beamed virtually from Twickenham, I think, Richard, wasn't it? And what I wanted to sort of start by saying is that my day job, actually, I'm a chest radiologist in a local district general hospital with not many resources, with understaffing with our radiographer colleagues and radiology colleagues, with imaging backlogs, with frustrations with information governance and how quickly or slowly IT changes happen, and the inertia that sometimes prevents us from doing things. So I sort of get it at that level. I've worked with a lot of you, actually, in many different hospitals that I've met you in the lobby today. And actually, I think we do know where we want to go. And we just need trust CFOs, trust CEOs to realize that imaging has gone, and diagnostics has gone to the top of the agenda in terms of our healthcare system. And if, as managers, you're not getting that connection at that level, at your trusts and regions, you should let us know. And I just want to, before I carry on with this talk, give a shout out to the work that's gone on, which I'm going to talk to you about, to the National Imaging Team. Forgive me if I forget anyone, but that's myself as the National Advisor for Imaging, that's Kim Robertson as the Head of Transformation, that's Alex Cook on Workforce, it's Josh, Barry, Sheila Black, who's the Deputy Lead working with us, and the Imaging Team nationally is growing, and Graham Robinson, who's the National IT and Imaging Lead. And, you know, we will deliver this program, and I'm hoping to show you that this isn't just about high-level stuff and we give the same talk every year and nothing's happened. Things are happening, and it's a fantastic time to be part of imaging and radiology, and I think that's the feeling that you should all have in this room. Never has there been a better time for our discipline in diagnostics, of which imaging is the biggest part, but actually there's an opportunity here, and I think I'm all about hearing about the positive stories and the real changes that have been made. Often, you know, on Twitter and these types of fora and the media, you hear about negative things, and it seems like the naysayers often have the loudest voice. But actually, it's about time that the positive progress that's been made had the louder voice, because that's how we make a real difference. And why are we doing this? You know, I haven't shown you a single slide, and I can talk about this for 2 hours, but why are we doing this? And you will never lose if you realize that you're doing this for our patients. And much of what I'm going to talk to you about is why we're doing this. We're doing it for our patients, to make our healthcare system better, to make imaging better. And I could summarize and finish here saying that that's the reason we do everything, and that's why I'm grateful to Sir Mike Richards for writing this report, because when it landed, I wasn't in this role. This was in October 2020 I got this role. I was like, thank you, Sir Mike, for articulating what we've all been feeling in the imaging world and the diagnostic world for 20 years, and thank you for writing a report that, you know, might actually get delivered and make us make a difference in what we do for patients. So has there been progress? There has. I'm going to talk a little bit about that. October 2020 was the Richards report, and there was a slight delay in the publication of this report because COVID happened. Now, COVID was devastating, you know, for a lot of people. It was devastating for the imaging community. We tried, but, you know, I hope in your institutions there was recognition of how much radiographers and the wider imaging workforce contributed to the COVID pandemic. Every patient had an X-ray. It wasn't just about, you know, COVID ward rounds and respiratory wards. None of that would have happened without the radiography and the radiology and the working in the night to report chest X-rays hot off the press. And that should be recognized. But what ultimately was recognized in the Richards report, one positive, if you want to say, that came out of the pandemic, was the final realization that without imaging and diagnostics, I'm going to say imaging, but I mean diagnostics because this is an imaging conference, no pathways can ever come to fruition. Everything stopped. Cancer patients couldn't see their oncologists because their scans weren't reported. Biopsies stopped. everything came to a halt. And finally, I think a light bulb moment must have gone off somewhere to say, actually, without imaging and diagnostics, we have nothing. And I've always said that imaging and diagnostic is the hub of the hospital, it's the workhorse, it's what enables patients to get decisions and treatment plans set up. And this report helps articulate that and recognizes that we need to increase our diagnostic capacity. And there's 5 main facets of that. There's new service delivery models and community diagnostic centers. There's new equipment, there's workforce, which we'll talk about, which is the biggest challenge. There's digitization and connectivity, which in my belief underpins everything we want to deliver, and that's the core to getting where we want to get to. And there's delivering the change enablers, and I think the biggest challenge is actually not workforce, I think it's culture in the NHS, silo mentality working, not sharing, not using NHS number, failing to recognize that patients cross geographical boundaries every single day. My daughter, bless her, goes to Great Ormond Street, and she's got a chronic illness. We see patients there, and I talk to them, and they travel from Aberdeen and Manchester and London. And isn't it sad that the imaging that has been taken with them in those hospitals doesn't travel with them, bar anything other than IEP, which is now outdated, and we need to upgrade that. And that's real life, My daughter's imaging doesn't travel with her to Great Ormond Street beyond anything other than IEP, and we live in London. So that's the challenge we face. And we need to reflect as managers, why do we think we have those challenges? Why are we not sharing images when patients? Because I'll tell you one thing, when a patient sits opposite a clinician and that clinician says, I'm sorry, your imaging was done at a hospital down the road and I can't see it, and I can't see your report. Should we repeat the scan or come back in a couple of weeks' time and we'll see you again once the images are in? That's unacceptable to me. And that's part of the reason why we're developing imaging networks, and because it's for our patients. A patient shouldn't be sitting in front of a clinician, because that patient will ask, but I had my test done in the NHS, Dr. Smith, why can't you see my imaging? And I don't know what the answer to that is, but it shouldn't be that we don't have the technological capability in this country to deliver that. I was in Scotland for a lecture 2 weeks ago, and they have a national PACS, imaging from anywhere. It's possible in the private sector, so you then have to ask yourself, what are the barriers, what are the real barriers to change? Because with the Richards report, it's not really funding. It's not the will of the radiology workforce and the patients. It isn't the technology around upgrading our digital systems. It's not the delivery of community diagnostic centres. So what actually is it? And it's a rhetorical question, because I think deep down we all know what it is. And that's the barrier that we have to change and break through. Because cultural barriers, in my mind, don't count for anything. As I said 2 years ago, and the NHS isn't about sovereign NHS trusts or sovereign organisations. It's about patient sovereignty. And that's the only thing that is sovereign in the NHS is the patient and the care they should be getting. So if that isn't reflected at your trusts, for whatever reason, it should be. And that's the message I'd like you to take back to your trusts. 5 categories of diagnostics, all of which have had lots of funding, but imaging obviously is the big one, as we all know. A lot of work going on there. So community diagnostic hubs, as they were called, rebranded to community diagnostic centres. And that's been a large focus of some of the work that we're doing. And this is about working differently and delivering diagnostics with an attempted split between acute and elective. As I said, I'm a DGH radiologist. How many years have I gone to my single CT scanner? We now have 2, luckily, and said to the radiographers, I'm really sorry, I've got an urgent inpatient who's got abdominal pain. Can you please put them on the scanner? But they've got a stacked list of outpatients on the same scanner, and you have to slot them in. We know about all these problems. So the issue with CDCs is, the attempt is, we want to move out elective care, your CT KUB, your CT brain doesn't need contrast, etc. An easy examination that can be done in another diagnostic facility in the heart of the community, which patients can access, get that imaging done. And so you theoretically should be scanning more inpatients, doing more biopsies, doing more interventional patients on the scanners that you have, because for too long we've tried to fit in inpatients and outpatients onto the same scanners, and it's just not good enough. And part of that has been we haven't had the facilities to do it, but we are having now. And the CDC model is also shifting towards a pathway-based approach, because that's sensible, and I'll explain why. And we've now delivered 930,000, actually the slide's a bit outdated, because we've got 930,000 tests or diagnostic tests since July 21, which is a lot of extra capacity. But I hope, and it should be like this, that in your local hospitals you are seeing an increased throughput of inpatient scanning and things like that, because you should be using that increased capacity and working differently to capitalize on it. We can talk about that later. So the vision and purpose of CDCs, we all know, to improve health outcomes, to increase diagnostic capacity. And that is happening. You know, I've got a community diagnostic centre down the road from me, Finchley Memorial. We're doing our 2-week wait lung cancer, non-contrast, straight to CT tests there. The patients are coming through quickly. We're getting them reported quickly. Yes, we have some workforce issues, but that's being tackled. We do more ultrasounds. There's a bit of ophthalmology. There's phlebotomy, and things are happening. So that's my local CDC. And, you know, when I'm 10, 20 years older, or maybe soon, I'll be using that CDC to have my diagnostics. And thank God I can go to one place and get my blood test and CT scan done in the same place rather than 2 or 3 hospital visits, which leads to delays in pathways, because that's what it's all about. There's 3 types of models that have been identified in CDCs. There's your sort of standard model, which has to, from the imaging perspective, have CT, MRI, X-ray, and ultrasound with some phlebotomy and other stuff. There's a large CDC model, which might have endoscopy, might even be part of an academy, and you could, you know, what a great career progression for a radiographer who does CT colonography to go to a large CDC and also be able to do some CT colonography, but also to be able to see some endoscopy, because the 2 tests go hand in hand, and that's the type of thing that's possible. And then there's a hub and spoke model where you reach out into smaller facilities. But as I've said, none of this, what you don't want to end up with is islands within islands that are not digitally connected. So there's no point doing 930,000 new tests in swanky new facilities or repurposed old facilities if they can't go beyond anywhere outside of that facility, and the radiologist or the reporting radiographer can't see the scans or the images to be able to report on where they work. So all of this is great, but as I always say, you can have, you know, the 5 largest, most swanky cities in England, but if the motorways that connect them are not fit for purpose, then you're not going to visit all of them, and it's a waste of time. You'll be stuck in one. So it's about the motorways and the highways that connect these facilities, and that's where we need to put a lot of focus. I'm not going to dwell too much on this. The aim is to have a sort of a, you know, timely referral, seeing patients quickly, getting testing done on one visit, getting them reported, but it all depends on digital connectivity. Now, I know, you know, from personal experience in seeing patients day to day, you know, particularly in my, you know, lung cancer pathway, how frustrated they often feel that they have to come to get a CT scan and go somewhere else to have a blood test and go somewhere else to have lung function, and how good it would be if we were able to navigate those patients under one umbrella to have those tests on the same day. That's why a lot of our workforce work is on funding radiology navigators, which I think is really important. Dedicated radiology-based navigators who can see what tests the patients are having, when they are having, because as I've always said, imaging is the one discipline that almost has oversight of all the tests the patient is having. And sometimes the clinical teams don't have that oversight. It's the same as at MDTs. When we do a lung cancer MDT, as an imager, I can see that the patient had a PET scan 3 weeks ago or had this test then or an echo then. And in some ways in imaging, we are the hub that can see all this. And if you had a radiology-based navigator coordinating these tests, and, you know, I ask myself the question, why have we not had this for the last 10 or 20 years? Why has imaging been neglected so much that we haven't had radiology-based navigators? So it's time to change that and ask that question locally of your trusts and hospitals and where you work. So there is change. There's increasing CDC activity every week. We monitor this. We get weekly reports. It's done region by region. You know, it's regular, so stuff is happening. We're monitoring that progress. This is by modality. So you can see the main increases in CT capacity, but there's a lot of DEXA, there's a fair bit of MRI, and even some, well, less MRI, but a fair bit of a non-obstetric ultrasound as well. But this will be local to your region. And that's great, because not all CDCs are the same. You know, you might have a region which has no CT backlog but needs loads of MRI capacity, and so you should be able to use that. And so this model offers you the flexibility to cater to local needs, but but overall adhere to some common principles of CDCs which should always be respected, which is accessible for patients, using NHS number as the unique patient identifier, trying to do more than one test on a single visit, and those types of things. There's some new CDC location maps for 2022, 2023, so these are going up and getting started all the time, and we're trying to distribute them out depending on, health inequalities and deprivation, etc. So, a lot is happening. That is progress. That's real life, tangible progress. There is a plan. These are some of the pathways we've talked about. So breathlessness pathway is the one I've talked about. Forget the content of the slide, but the whole purpose of it is to streamline your pathway and make it much more compact rather than the top bit, which is what we're doing now. And it can take 9 months for a patient to progress through a breathlessness pathway. But if you coordinate your CT scan, your ECG, your lung function tests, your blood tests in one visit, of course you're going to speed up the pathway and patients are going to get their diagnoses quicker. Still have to deliver it with the workforce though, so we'll come to that. And so this is partly what I was talking about at the very beginning. What's the approach for rolling out these pathways? We encourage it in talks like this, but we go out and we identify a successful pathway that's being delivered. And Sir Mike has been visiting all the CDCs around the country, and his vision is to visit every one. And you identify a pathway that works, and you adapt it, and deliver it. And that's how you get stuff done. There are good pathways out there. We just need to communicate better about what we're doing in each of our systems, liaise with each other, pass on those good ideas so that we can disseminate them. And I've been here now. I was in Canada. We've talked about the NHS 5-year forward view and the 10-year plan. Part of that is the faster dissemination of innovation. We talk about it, but we don't do it. So it's time to start doing, because that principle holds true. There's great pathways out there, great breathlessness pathways, great ultrasound pathways, great new innovative ways of working. And actually it is often at the DGHs where the resources are less, and so they've found ways to adapt. And my very own ambulatory lung biopsy pathway at Barnet Hospital, which was done with no resource, no extra funding, saved the NHS a hell of a load of money by doing all lung biopsies outpatients, saving beds. Didn't need extra resources for that. We just needed to work differently. And now that's becoming adopted in a lot of other trusts as an exemplar pathway. So I've always said, maybe look more to your DGHs and what they're doing, because there's a hell of a lot of innovative pathways out there, but they don't often get the traction or the publicity as some of the other pathways in the bigger teaching hospitals, which are delivered with lots and lots of extra funding. But the NHS is about doing what you can at the smallest DGH with the lowest resource and innovating and spreading that type of pathway. And so, as I've said to you, I think 2 years ago, I'd love to see a change and a bottom-up approach of dissemination rather than a top-down approach, because I think that's more likely to be successful and sustainable. So this is the question I always get asked every Teams meeting. You'll ask it here, so I'm just going to answer it now, actually. So I thought about this, and I thought, and worked with Alex Cook on the workforce side, and I thought about this question. We as NHS England and the team, we have a plan. We recognise that workforce is a challenge. You can't magic up 6,000 new human beings overnight and start doing loads of scanning, right? But that shouldn't be a reason for us to get part of the way there by working differently. So there's a lot of spending review funding going into more posts, and that's not just in imaging, that's in pathology, that's in endoscopy. I'm going to show you a bigger version of this slide in a second. But I'm going to talk about radiology training places, because that's, it's not radiographers, but it's radiologists. So there's funding for 100 plus, 120 plus new radiology registrar trainees every single year now, which is massive. So we should have more radiologists. The funding is there. But I keep getting emails about, oh, Sam, my trust, because of the way the funding is done, 50% funded by HEE, 50% funded by the trust. The trust isn't keen to fund the 50% for a year one radiology trainee because they don't think they offer that much service. And so you get stuck there. And we've got all these places. We've talked for ages about how there's not enough radiologists. The training places are being delivered, and then they're not being taken up by training schemes, which I think is a travesty and isn't the way that things should be done. And my comment to any trust that comes with that type of comment is that everybody at some stage in their career was a year one accountant or a year one CEO or a year one radiographer or a year one radiologist, and you can never get to a year 5 unless you've been a year 1. So that argument doesn't ever wash with me. We're supposed to be building for the future. And if you think about it, why should we be taking these radiology training places and filling them? because it's the right thing for the patients, because we always moan about lack of workforce. So the opportunity is there to do something about it. So you've got to take it. Otherwise, you're just going to keep on hearing the same people talking the same year. Every year we don't have the workforce. But there's an opportunity to do something about it in this space. So medical directors, trust CFOs, trust CEOs, let's do something about it, and let's do this funding, and let's get these radiology trainees into posts, and let's get more diagnostics done, and let's get more pathways completed faster. This is just some of the plan. So we're focusing on recruitment and supply. We're focusing on retention. We're focusing on outsourcing and also working with independent sector. So let's ask that. Independent sector. In COVID, a lot of what we achieved was in partnership with the independent sector. That's how we got diagnostics done. And we shouldn't just forget that. And I think part of the thing I see at my DGH, and part of the frustration is, we did a hell of a lot during the COVID pandemic. Things happened fast in the pandemic. So we'd fought for 7 years to get home reporting at my hospital. And there might be some managers from my hospital in the audience, actually. And it was going nowhere. COVID happened, and we all got workstations within 2 weeks. So it's possible to do it, but we've sort of gone back to our old ways of 5 committees, and it has to be signed off by this person. And often the committees are just full of the same people in different roles. And it's just like, why are we doing this? Let's just crack on. We've got a program to deliver for the good of our patients. So we do need to cut through some of that red tape. I don't know how that happens, but it's something that we should be lobbying for. We're focusing on working differently, skill mix, digital and technology. But ultimately, we need to focus on culture. Because as I've said, if you have the right culture and an openness to share your images and work across networks and realize that you're always working for the good of your patients rather than what's best for your local trust. Because I think sometimes, and sadly, we forget that, yes, I work for a trust, but actually all trusts are part of the NHS. We work for the NHS, we don't only work for our trust. And when you're a patient on the ground traveling to 3 different trusts for your care, there's no value in saying, well, my trust does this and doesn't talk to your trust, and I don't talk to your trust because historically we did this and your service is here and my service is there. Because to the patient, that's irrelevant, and that's what we should focus on. So, multicolored slide, just to show that imaging workforce isn't just radiographers and radiologists. And the story I often tell is, I used to turn up on call on a Saturday to an ultrasound list at my local hospital, radiology managers. I don't know if there's any of you from the Royal Free here. And I've had to wheel patients down in chairs from wards myself because there isn't a radiology porter and there's no admin person in the front desk to book the patient onto CRIS so that once I've done the scan, I can put the report onto PACS, and I'm having to do that myself. And come on, we've got to invest in our support workforce, because without the support workforce, there's no point me coming into work on a Saturday and doing my on-call. I'm just completely inefficient. I could do so much more. So this is about radiology navigators, it's about healthcare practitioners, it's about physicists, and it's about mammographers and sonographers and admin and clerical staff, which have been stripped from radiology for far too long, much to the detriment. And now we have to undo all that and re-bring them all back in, because we have to book all these patients into CDCs and get diagnostics done faster. So that stripping out of admin and clerical that happened in a lot of radiology departments now has to be reversed, because diagnostics is what it's all about. No pathway goes forward without timely diagnostics and accuracy of reporting. There is a diagnostic workforce governance structure. It changes all the time, but ultimately each pillar, imaging, pathology, endoscopy, physiological measurement, and genomics, has a workforce group, and that feeds into an overall diagnostic workforce group, which is chaired by Steve Powis and people at NHS England. So there is a mechanism for these types of things to filter up the chain, and we do have a governance structure. But what I'd like to hear, and we can talk about in the questions, is we have this where we work. So in the national imaging team, me as a radiologist, Kim, Sheila, Alex as radiographers, we work as a team, radiologists, radiographers, not quite hand in hand, but you know what I mean metaphorically. We work together because we know that's how real life radiology is delivered. And I'm hoping that in all your departments, as ops managers and radiologists and radiographers, you are also working together, because that's what we try to emulate at the national team. And we're hoping that's what happens on the ground. But I know culturally from working in some departments that doesn't happen. And, well, I'm a radiologist, and this radiographer, well, I don't know if radiographers should do radiographer reporting, blah, blah, blah. We don't operate like that. We all work for the same imaging community. We're all there to deliver the right care for our patients, and that means working together. And I don't recognize a radiologist versus a radiographer versus a sonographer. We're all part of the same team, and if we can't all do our jobs optimally, everybody suffers, the patients and the department. So that's the way you should run a radiology department, I think. We have diagnostic workforce boards, as I've said. We've got an imaging advisory committee, which I chair, which has lots of regional input. And the reason for that is I don't want to be standing here, and we don't want to be standing here telling people on the ground, this should be done, this should be done. We want a two-way feedback. We want to hear from the regions what you need help with in the national team, what we can do for you, what your local needs are, and that's why we have this advisory committee. Slightly above that sits the formal imaging workforce group chaired by my esteemed colleague Suzanne Rastrick, who's also chair of the AHPs, and myself, and that's where we discuss policy and delivery and things, on academies and CDCs and how we're going to address the workforce issues and how we identify our priorities. And then there's the overall Diagnostic Workforce Board, which feeds into the executive board at the NHS England. So there is a structure, and hopefully much of that structure is being mimicked on the ground, because, regionally or system-wide, because that would be handy. Some of our priorities, which hopefully you can see, but I've talked about this, is increasing digital connectivity, educational infrastructure, recruitment, network, CDCs, and obviously learning to adapt because of the pandemic. Because, so one of the common things that comes up is in meetings, we need to focus on elective recovery. We need to focus on elective recovery. It depends what you mean by elective recovery. To me, elective recovery is the recovery of imaging over the last 2 decades of underfunding. It isn't just the recovery of a waiting list of COVID backlog studies. And as I always say, unless you start to tackle the wider implications of imaging and the underfunding and just only focus on this waiting list, that's, I know resources tight, and I know we do have to clear the waiting list. But if we only focus on that, we're going to have an endless forward log and be in an endless backlog for the rest of our lives and never be able to get out of it. So for me, backlog is upgrading, imaging, workforce, digital connectivity for the last 20 years where we've been under-resourced. Funding is coming, so please do capitalize on that opportunity to work differently, and I know that may be challenging. And again, just another schematic on some of the stuff. But the thing at the top, the lessons learned and the recovery from COVID-19. We learned a lot of lessons in COVID-19. Things happened fast. And I don't know why we've gone back to how we used to do things before, because COVID is gone, because that was a positive. We got stuff done quickly. There was less red tape. So it'd be good to bring back some of that culture that we had at that time. Because we had the same resources at that time, but we were willing to work differently because of the challenges we were faced with in a pandemic. But we need to recognize that we've been challenged in imaging and diagnostics for 20 years. So we're constantly working under challenge, so it is time to work differently. A little bit about what else is new. So the National Imaging Optimization Delivery Board, which we can't even pronounce, is now the National Imaging Board. It's just simple. We want to try and achieve NHS number. I can talk about this with some of the PACS providers, actually, as the unique patient identifier across systems, rather than have lockdown systems based on individual hospital numbers, so that when an image comes in on an IEP from one hospital, in my hospital, you can never see the images side by side because they come in as the MRN as the unique identifier, but if they came in as NHS number as the unique identifier, they'd automatically link up. We're going for a bit more of a clinical standardization approach, so we've got a national optimal stroke pathway, national optimal CT colon pathway, which you'll have maybe heard about, and had some success with the pricing team, where CT colonography now is recognized as a formal complex CT tariff. So when you do CT colons, you're going to be paid more than you were before just for doing a CT abdomen and pelvis, because it is a complex CT. It does take longer on your scanner. You do have to do supine and prone views. And before, it was only CT coronary angiogram that was recognized like that. So there's an opportunity now to do more CT colons, because you're going to be paid more for them as radiology departments. So you should make sure that you go to your trust CFOs and CEOs and say, actually, CTC is now at this tariff. We need to see that money flowing back into imaging so we can then spend it on a radiology navigator, for example. And we're trying to work on MSK in the same way. We created the Imaging, Digital and IT subcommittee to try and accelerate some of our ideas around digital connectivity and how do we implement AI in the NHS, because traditionally it's been a trust-by-trust approach. My trust wants this AI, my trust wants this AI, and my trust over there wants this AI, but no joined-up thinking. And these are the types of things and innovations that should be, maybe be delivered at a macro level, so more people benefit with a more of a standardized approach. I've talked about networks, I've talked about investment, and I've talked about radiology training posts. This hasn't actually changed, but I want it here because I remember 1.5 years ago in Twickenham, there was a big article in the press about imaging networks and the governance model around them. Bit of a hoo-ha about nothing, actually, but imaging networks are there to deliver good change for patients. There has to be an agreed operational governance structure. It's run by NHS trusts. It facilitates shared reporting work lists. There's a workforce plan for it. There's capital equipment gone into it. And there should be agreed processes and methodology for demand and capacity modeling. That's the same, and I'm hoping locally with your networks that things have progressed at some level. But we can talk about that at the questions. Because ultimately, what has changed is we're thinking, okay, should we stop at regional networks? Is it acceptable to work in an NHS where we used to have small islands, but now we're going to have bigger islands, regional networks, and do we just stop there? Or do we want to achieve this visionary world-class NHS where the bigger islands actually talk to each other? Because we know that patients cross those islands and hop from different hospitals across boundaries all the time. So why should we be happy with just having networks that stop there? And what we could achieve if we think beyond just our imaging network is, let's just say, and it's hypothetical, but this is hopefully where we might end up, let's say we had a situation where we had a national registry, or whatever you want to call it, where all imaging done across the NHS England, Scotland already has this, so we're way behind, where it was visible. So, I don't know, if my dad breaks his wrist in Swindon meeting his sister, and has an x-ray in Swindon and comes to me and says, Sam, can you look at this x-ray? I don't have to say to him, sorry, Dad, you were in the same country and in the same organization, but I can't see your x-ray. I have to wait for IEP. It might take a few days, blah, 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 blah. What if I could just type his NHS number and then see his x-ray and see his report? It would save him a hell of a lot of hassle, but it would save us a lot of duplication and that mentality of, well, let's just get another x-ray, because I don't know how long it's going to take to get the one from Swindon. That's what we could achieve. So what I'm saying is networks shouldn't be the end. You should always be thinking about where else we can go. What would a national registry allow, theoretically? It would allow national image sharing. It might allow national reporting if that's what we want. It might allow national report access. Might even, God forbid, allow a national PACS, who knows. It would allow the rollout of AI at a macro level across multiple images rather than at a trust level, which is what AI needs. AI needs loads of data. So it's ideal for that. Could we have a national AI procurement framework? Could we have a national data set for research, etc., and validation? Could we do national research? Could we have real-time business intelligence about what is actually the backlog and what is actually going on out there? Could we come together as a radiology community and share the NHS backlog for reporting in the NHS and pool our resources as NHS radiologists? Could we, and radiographers, and the world is our oyster if we think beyond that. And so that's just an idea of what we're talking about nationally. A long way to go. There is funding for digital connectivity and increasing that. And this would allow us to then deliver our CDCs and not have imaging in CDCs just siloed on the high street and not being able to communicate with your hospital system and A&E departments, etc. And I'll just stop there. So I think just lastly, I wanted to say thanks and recognition to the National Imaging team. We are here, send us thoughts, emails. But it's about two things, ultimately, for me. There's a lot of buff in the middle, but we're doing this for our patients. That's the sole focus, and that's what should drive us to do anything. And I think the biggest barrier is cultural change, and I think that's changeable because it all depends on each one of us in the room, and we can deliver that change locally by how we talk and talk to our colleagues and fight for change by making the patient always the centrepiece of what we're trying to do. Thank you very much.
Thank you so much, Sam, for starting our conference with an amazing keynote. Does anybody have a question? We've got some microphones around, so we can come to you. I wondered, you shocked us all by saying workforce wasn't the big challenge, it was culture. Bringing those together, I mean, because workforce is undoubtedly a big challenge, as you noticed. What elements of culture do you think we should be looking at to change that will help the workforce crisis? Because it will take time. We haven't got time. We've got to survive in the meantime. We've got to innovate and what have you. So what cultural things are getting in the way of the best workforce practice, in your opinion?
I think it's the culture to work differently and accept that we need to work differently, accept that we're not going to get 6,000 new people overnight. So we have an opportunity here. We have funding, and loads of it, for the first time in a long time in imaging. And wouldn't it be sad to not take advantage of that if we're so wedded in our ways of how we work differently? So two models, and these are open to challenge, but there's two models that I've seen that are different ways of working, and they may work and they might not work, and you might have to go abroad to see them. So there's the model of, which I think I'm going to ask a question in this room, do you always need 2 radiographers for every CT list? Let's say the examinations are all non-contrast, or could you do that with a radiographer and a support care worker? Do we always need a consultant radiologist in one room doing an ultrasound list? Or could you do this in an academy with 5 rooms, 2 radiology registrars, 3 sonographers, and 1 consultant supervising all 5 of them? Because I've certainly seen those models in certain places, in this country and abroad. But whenever you mention them, there is resistance for some reason. So I guess my question, I can come back to you, Richard, or what you think is, why that resistance? Because surely we have an opportunity to work differently and use our workforce to deliver change for the good of our patients by working differently. So what would be your answer, anybody in the room, to those 2 models of care? Why are we so anti doing it differently? Or are we not? And is that a misperception? Anyone?
You may be preaching to the converted in this room.
That's, I
suspect.
I said that, so I'll finish there. We did a workforce event, and everybody loved it. It was a few weeks ago, and it was great, and it was fantastic, and it was great to see everybody. But I think I said, and we all recognised it, the people in the room, they're the believers and the people who want to get stuff done. It's how do you engage with the people that aren't in this room? And, you know, we could all go out of here and say, yeah, this is fantastic, great talk, you know, let's do this. But how do we engage with the people in this room? Because often they're the blockers. But actually, should they be? Because if you preach and show them examples of where things can be done differently. I don't want to be sitting here in this role, if I am in this role at the end of it. It's a 3-year tenure, but it might go on. I don't want to be sitting here having the same conversation. So that's not what I'm about. I'm about actually doing stuff and making a difference. I'm just fed up of saying the same stuff. And sometimes, I think a phrase that I was taught in Canada, I don't mean it in any derogatory way or aggressive way. It's sometimes to make an omelette, you have to break an egg. Well, actually, always. So it depends on if you like omelettes or not, I guess.
We can see a question or a comment.
Hello there, I'm Hayley. I work at Walsall Manor in the Midlands. Walsall Manor is a very strange place, really. It's very... yeah, you all probably know it, that's why they're laughing. It's very, the culture is very wrong. They wanted a change, but we often joke that they do things on a champagne, they want a champagne lifestyle on a lemonade budget. How you've kind of given me today a little bit of inspiration, because I do believe that, you know, we need to be telling the people in the ops centre, and, you know, we need to be encouraging and educating people. What's the most effective way, do you feel, for people like us to do that?
It's the patient. So as I said, I've given this story before, but I'm going to say it again. Kim will roll her eyes because I always give it. So my father went to have a CT coronary angiogram, where I work actually, and it was all fine, it was great. Then he went to see a cardiologist at another hospital in the region, in London, to discuss the results of that exam. And the cardiologist said, "I'm sorry, Mr. Hare," I was with him. "I can't see the report or the images from your coronary angiogram and might need to reschedule your appointment." And my dad looked at me and said, "Sam, isn't this what you're supposed to be doing in your job as NHS advisor?" And I was embarrassed, more so when I went to Scotland and how amazing their system is. And they showed me a scan from Fife or Aberdeen, and it can be seen in Edinburgh. And I thought, isn't it sad that our patients in England don't have this? So I'm not, I know it's harder, but I think somebody just has to call it how it is. What's right for the patient is the only thing that matters to me. And I'm annoyed that my dad had to go for a second visit. I'm annoyed because I know how we can deliver the change, but I'm most annoyed at the blockers that are in the way to help us doing that.
Thank you. There's another, I think we've got just time for one more.
Sam, thank you. Very, very interesting presentation, and I think you touched on a key thing, which is culture. So I'm a radiologist. I also work for Alliance Medical. One of the cultural things we get challenged about is our safe staffing model by the CQC. So we might have a radiographer and a clinical assistant running a CT list, and the CQC will come in, and they have done recently, and challenged us to say, is that a safe staffing model? So maybe that's one cultural aspect that maybe needs to be thought about. Another one, my local DGH is also up in the Midlands, not a million miles from Walsall, it's Dudley actually. The challenge they've got with their local CDC that they're trying to set up is it's the clinicians that are saying, we don't have the capacity for one-stop shops. So as the imaging department, we've come up with ideas for one-stop shops that also have a clinician somewhere in the middle to see the patient, review tests and blood results with them and so on. And it's the clinicians now that are saying, actually, we're the ones that don't have enough staff to put that person into the clinic room in the CDC. You guys run it without us. And it feels that there's a culture there that needs to change as well.
I agree with that. So clinical culture needs to change. And I've just said, I love my clinicians and stuff, but we've been running the NHS with, I guess, clinicians determining, writing pathways for the last 20 years, and it hasn't really worked. So maybe imaging should be leading the construct of pathways and designing them, because maybe it's our time to see if we can do better and we can change the culture. As I said, we always know what we want, and Mike Richards has articulated that in the report, which is why it's so exciting. We just need to create a movement and get this done, because I think we've got a central edict to deliver this. We've actually got a report that might get delivered, Mike says. So it actually might get delivered, and that's really exciting. And you shouldn't let that type of clinical opinion stop you. And I would say, well, it is a safe model of working, that one, because it's done in other places. So I would ask, why is it unsafe to the CQC? I don't know if you asked that question back, but it's a fair question to ask back, I think.
Thank you, Sam. Let's give him a big round of applause.